Good afternoon. I'd like to thank the panel and the World Congress for allowing us to present our data here today. We don't have any disclosures. The benefits as well as the complications of laparoscopic Roux-en-Y gastric bypass have been well documented. And we are going to present our patient population as a comparison of the type of gastrojejunal anastomosis that can be created during the gastric bypass. Many techniques have been described in performing the gastrojejunal anastomosis, including circular stapled, linear stapled, and hand-sewn anastomosis. And complications including leak as well as other late complications in the form of stricture have been documented. Our patient population was retrospectively reviewed on data that was prospectively obtained on patients undergoing laparoscopic Roux-en-Y gastric bypass over a 3-year period from July 2006 through June 2009. This was a single-centered study in a tertiary care center. On all procedures were done by a single surgeon. The first 99 patients obtained linear stapled anastomoses, and the next 123 patients obtained hand-sewn anastomosis. In brief, the operations were fairly the same, with the exception of the GJ Anastomosis. In the stapled group, all patients underwent a 2-layered anticolic antigastric anastomosis with a 20 milliliter pouch, and an outer layer that was had a seromuscular approximation with a 2-0 Surgidac suture. The inner layer of the stapled group had a 3.5 millimeter blue load linear staple anastomosis with an 18 millimeter length, and that defect was closed with 2-0 absorbable suture. The hand-sewn anastomosis was done the same way for the outer layer, and the inner layer was completed with a completely hand-sewn full thickness approximation of an 18 millimeter approximation of a gastrotomy and enterotomy. All patients underwent intraoperative leak tests, and if there was any leak that was detected, they were repaired with 2-0 polysorb suture at the time that it was detected. A number 10 flat JP drain was placed over the top of the anastomosis, and all patients underwent a upper GI study on postoperative day number 1. We collected data on 226 patients who underwent the laparoscopic gastric bypass over that 3-year period. 3 patients were excluded for having revisional surgery, and 1 patient was excluded for having been converted to an open procedure for technical complications with a conversion rate of approximately 0.5%. This left a total of 222 patients available for analysis. Our results showed that 99 patients had stapled anastomoses, and of those patients, 1 had a gastrojejunal anastomotic leak, 1 had a late perforated GJ ulcer, and 10 had GJ strictures. The 123 patients who had hand-sewn anastomoses had also 1 had an anastomotic leak, and 5 had strictures. This is our demographics of our populations that are compared. And as you can see, the operating time and the presence of dyslipidemia were the 2 that were statistically significant differences. 10 patients underwent early reoperation, 4 from the stapled group and 6 from the hand-sewn group. The average length of stay of the patients who underwent early reoperation was approximately 5 days, and then this was increased by about 3 days over those patients who did not have to undergo early reoperation. 1 had a negative exploration, and this was secondary to a false positive upper GI study. 2 patients had GJ Anastomotic leaks, and all complications were managed laparoscopically. We had no deaths. The GJ Anastomotic leak, there was approximately 1% from each group, and the one patient who had the stapled anastomosis had a length of stay of 3 days. The other patient had a length of stay of 10 days. Both were discharged home in good condition and without the need for parenteral nutrition. This is a description of our patients who underwent early reoperation. These are the 2 patients who had GJ anastomotic leaks. Again, we had one iatrogenic enterotomy that was repaired, and 1 patient with a diagnostic laparoscopy. We had 10 patients from the stapled group who had strictures, and 5 patients from the hand-sewn group who had strictures. 3 patients in the stapled group underwent 2 dilatations with a pneumatic balloon dilatation, and 1 patient had 2 dilatations from the hand-sewn group, and another patient had 4. And all of these were managed with the balloon dilatation and without complication. The linear stapled anastomosis was more likely to form a stricture, although this was not a statistically significant finding. And we did note that the time to dilatation in the stapled group was approximately 48 days. And the hand-sewn group, they tended to form strictures at a later time point, and this was a statistically significant finding. So in summary, our early reoperation rates were approximately 4% in each group. The GJ anastomotic leak was also approximately the same at 1%, and stricture formation tended to be higher in the stapled group with a percentage of 10% in the stapled group as opposed to 4% in the hand-sewn group. In conclusion, the rate of GJ anastomotic leak and early reoperation is essentially equivalent between a linear stapled and a hand-sewn anastomosis. The limitations of the study included the retrospective nature of our study, as well as the chronology of the patients getting the anastomoses, as all of the stapled anastomoses were grouped in the beginning, and all of the hand-sewn were grouped in the end. Our operative times were improved in the hand-sewn group, and we feel that this was probably not due just to the learning curve, but definitely further randomized prospective studies are needed to delineate these findings. Thank you very much.